We have two really big news stories to tackle today. On the one hand, the CDC is recommending against any and all travel over Thanksgiving because of COVID-19. And then separately, we have optimistic news on the development of a COVID-19 vaccine. We're going to take these two stories together. I had previously planned to talk to Dr. Darria, emergency room physician, mom trained at Harvard and Yale, about the vaccine technology we're seeing because it is really historic. But then suddenly we heard from the CDC, a surprise briefing about traveling over Thanksgiving. And the CDC is raising the alarm, saying they're seeing an exponential growth of COVID-19 cases in America, more than 1 million in the last week. And they, speaking frankly, are alarmed and want us to stay put. So it's 2020. You have to make adjustments. And Dr. Darria was willing to talk about both of these things. So here's Dr. Darria.
On the one part, I'm not entirely surprised that they came out and said this because we are seeing rising numbers. We saw rising numbers in Canada after their Canadian Thanksgiving. And we know that a big part of COVID protection is keeping your pod intact and keeping your pod kind of isolated, your little bubble. What happens with the holidays? All of these bubbles are going to be disrupted, which means COVID is going to be spreading much more easily. So I see where they're coming from. I just wish they'd given us a little more actionable guidance.
Yes, and as you're talking about pods, all I'm thinking about is, no offense to my family, but I'm a little sick of my pod right about now. Which is what we've been hearing, right? That we've all been a little bit more relaxed, and even if we're not going to huge events, that we're expanding our social circles. There was a great question asked by an NPR journalist. I don't have her name, but I thought it was really a smart question. She said, the health officials keep on telling Americans that the whole reason why we're seeing this rise in cases is because of small gatherings, that we're getting together, our pods are bumping into each other. But are you sure? She was asking, are you sure that's the reason? Is it school? Is it activities? Is it restaurants? Is it gyms? Like, how do we really know it's because of our small, responsible gatherings? And the CDC said they actually don't really know. That's what they think. And so what do you think about that?
I think you can look at the data. You can do contact tracing and see where are the positive cases coming from. I mean, the CDC has reported on a number of cases. One recently, like Tennessee and I think Wisconsin, and they looked at if you live in a house with somebody and they have COVID, you have about a 50% chance of catching it. Is what they saw. I think it was 52 to 53% secondary infection rate when you live in the same house. They saw another report of a family that was from Arizona and that I think was really telling. There was one teenager went and then 13 family members all stayed together in the same house. 11 of them came down with COVID out of 13 people became positive from this one teenager. They had 6 other family members who didn't stay in the same house and just socialize outdoors. All 6 of them didn't get it. So when you're looking at households, you're getting pretty decent high secondary transmission rates. When you flip that to schools, Jenna, and I'm working with schools, as you know, what we're seeing is kind of the biggest risk is introduction from home. And when you see one sibling get it, then often it's another sibling who also has it, but less transmission within the schools. Because why? I mean, they're keeping a distance, they're wearing masks, they're not doing some of the things that we do at home that put us at higher risk.
So that was another interesting part of the call, how the CDC is defining households. So they want you to stay within your household. And one of the scenarios that came up, in part because one of the CDC's doctors has a child in college, was basically making very clear that even if you have family members that are within your immediate circle that haven't been living with you for the last 14 days, they're not considered part of your household. So some families, according to the way the CDC is looking at it, even if you have college students that are your son or daughter, the CDC is not considering them part of your household. So if they come and stay with you over the holidays, they want you to use different guidelines. What specifically should families do in that situation?
Yeah, and I think there was weird language to use. I mean, what parent is going to consider? I mean, your child can go off to the moon for 3 years and they come back. They're still my baby. So like they should have clarified.
My household. Yeah.
Like,
sometimes I don't want them to be, but like they are. Yeah. Forever.
They're like your 23-year-old college senior is still your baby. That's okay. But they're not your household in terms of COVID terms. So I think we need to separate out. We got to separate out the emotion because I am worried about kids coming home from college. They've been in these groups where there's a lot of contact that we know happens when you live in a dorm with somebody, and now they're spreading it to their other communities. And that's that's a problem with travel, is how quickly you can spread from one community to the other because one person traveled. I mean, that's how COVID spread in the first place. We knew those people who had traveled and had carried COVID with them. So I'm worried about that for college, especially if those kids come home and they are now around grandma and everything else. It's very easy to make those into kind of a super spreader event. It doesn't mean you don't love your kid. It just means you got to take some precautions. I mean, you just have to do that, even though they're your baby. So I would say the CDC mentioned a few things, which I thought made sense. Don't be sharing a bathroom. So that Arizona family that 11 of the 13 of them got sick, they shared 2 bathrooms. So that's a bad thing. That's a lot of intimate space there. Don't have them share a bathroom. They said in the house, not a bad idea to have them wear a mask. I know everybody hates wearing a mask, and your home is like the one place you don't have
In
to
your
wear a
home,
mask.
it's hard. I mean, that's hard,
Yeah.
right?
Yeah. But if you have that college student, and especially if you have any adults who are medically vulnerable, you may need to have them do that just for those, for those 2 weeks. A lot of college students are staying home for the rest of the semester. So just for 2 weeks, and then they're fine. I would have things like that. And then when you're eating, we know that kind of eating is kind of a high risk event, which is why restaurants and bars and places like that are higher risk. Then, distance them, have them sit a little bit further away. That's okay. Again, they don't have leprosy. You just want to keep them a little bit of a distance because you don't want to be spreading COVID. And especially the other thing, if I would just say one more thing, Jenna, is that if you have younger kids who are in school, as somebody who's advising schools, the things that worries me is older sibling comes home from college with COVID, now spreads it to younger sibling. Now younger sibling goes back to school. That's how you get outbreaks. So it really is important if you have a kid from college coming home.
Well, we should just emphasize, and the CDC did as well. These are recommendations. This is what they ideally, the guidance that they're providing to the American public. This is not an order. It's not a restriction. However, it is just, as we're filming this interview, it's about 2 hours since the CDC talked about this. And what I think we need to watch for is when the CDC does make these announcements, sometimes it gives some additional information to local and state officials who do want to put in stricter restrictions, however that might look. Not to say that you're going to be under a lockdown order, but it's just something to be aware of. When the CDC does this, then it can lead to an official citing them and saying, this is why we're going to do something with our gyms, for example, or restaurants.
Yeah.
So something to just be aware of. Do you think we're headed to that sort of scenario, Dr. Darria, now that we saw 1 million cases in 1 week alone, and the concern about where we might be next week?
I hope not. In terms of like large lockdowns, I really hope not. And I think there's a lot of little steps that we're still not doing when we talking about masks or talking about not having large gatherings. And we still have people you talk about them on Thanksgiving, and I hear people saying, well, I'm gonna have the same 40 people come over that I always do. Well, that's the problem. If we start little, then we don't have to go to the big lockdowns that nobody wants. I don't want them. I don't want to be shutting down our schools any more than we have to. But we have to pay attention to the little things so that and not wait until there is that level 3 emergency and we have to shut everything down.
And so again, the CDC is saying they're concerned about this, the rising cases, the hospitalizations, the death. When they were asked what are the stakes here, they were very clear that they're concerned that just through no fault of our own, we could be spreading a virus that could potentially hurt one of our family members, and that death could be the end result of that. And so they were very, while making it very clear that these were recommendations, they also were very clear about what's at stake. You're working hard in an emergency room, and one of the things I don't think we pay a close enough attention to is just how doctors are feeling about treating this illness, and how you're feeling now compared to how you felt in March. Do you feel better equipped, more able to treat somebody with COVID in the ER now compared to where you were a couple months ago?
Well, in terms of how to treat them, yes. I think we have a better idea. We have a better idea of who needs to be admitted, who can go home, and what to tell people. I mean, a few months ago, it was either we might admit you, we might not. If you go home, it's like, good luck. We hope you stay well. And now we actually have some guidance. I tell people what I want them to do, kind of an outpatient protocol. And we have a lot better therapies in terms of inpatient as well. So that is great in terms of how to treat people. In terms of testing, no. We still don't have enough testing, and we still are I'm still kind of rationing tests and trying to figure out who can get tests and who should get which
Really?
test. Yes. Yes.
Wow.
And talking to my doctors my friends nationwide, it's kind of the same thing. And you'll go from one day having plenty of tests to not having enough. So, and that is entirely community specific, whether they have enough tests. That's a problem. And in terms of having like the simple, again, the basics like PPE, Jenna, no, we're still having to ration our masks, the things that we kind of took for granted. Like we had N95 masks everywhere a year ago. Like you didn't even think about it. Now we put it on, and I have many colleagues. I have one, he keeps retaping his mask and he wears the same mask for a week.
Why is
Um,
that? I mean, why are we still in that situation? And I know it's specific to different communities. So,
right.
but you do have friends all over the country. So if you're seeing a pattern of that, well,
Mhm.
why are we still in that situation?
I don't know. I do not know why we, as a country in the United States of America today, cannot get enough N95 masks and not enough PPE. I have no answer for you because that strikes me as absolutely ridiculous.
Well, it's important to know that. And it's also important to know that you do feel more equipped, that you have learned over the last several months, because there are those that will say, hey, CDC, thanks for the recommendation. But the bottom line is that most people survive this illness. We know that it's deadly. We do know that, 250,000 people have passed away. So we know it's serious, but we also know that the vast majority of people that we know will likely be able to handle this. So why are we continuing to have these very strict recommendations? For someone that's feeling that way of saying, hey, like the reality is that we're going to be okay. Most of us are. We know it's deadly. We know it's serious, but we still have that. How would you handle someone that comes into the ER with that sort of perspective?
I think there's two things. One is the issue is hospital capacity. Our hospitals are full. We have this happen every year at flu season too. And the reality is our hospitals operate at 90% capacity as it is. And then many hospitals, because of volumes that had fallen in the summer, actually let go of employees. So many hospitals lost capacity. And now that our volumes and demand are increasing, you have a real problem. So that's part of it. Part of it, the CDC is saying, like even in my own hospital, our hospitals can't handle a sudden surge of COVID. As we saw in Italy, when you have overcapacity, you have a problem. New York was able to handle it because New York was the only, when they had their big epicenter of COVID, New York was the only county in the city in the US, aside from Washington, that was having a big outbreak. We had doctors and nurses flying from everywhere to New York. Well, we can't do that now because we have outbreaks happening everywhere. Nobody else is flying in to help us. So that's one reason. I think it's really a hospital capacity issue. And secondly, Jenna, there is this sporadic nature of who gets sick from COVID and who gets severely ill that we just don't understand, which is what makes it concerning. I mean, we also, yes, most people will get it and get better, especially if you're young and healthy. But we all know that 30 or 40-year-old who got COVID, who still is having that COVID long hauler syndrome, who still can't
Absolutely.
go back to work, or a child who got very ill who wasn't previously unhealthy. So we just don't know, and that unknown is, I think, a big driver what the CDC is talking about as well.
Well, it's something to take serious. It's great to have that perspective. I've talked to other doctors who say, and you've said this as much as well, which is, hey, listen, we know we can't put everybody in a bubble and just, isolate forever. We do have to live our lives. But the reality is if you do get COVID, you would like to get it when we have as many therapeutics as possible, where we have a great deal of knowledge about this. So if you can delay it, that's what this is sort of about. This is about delaying it so that we have time and that you as the patient get the better resources, which actually leads me to our next topic, which is the vaccines, right?
Mhm.
We have a lot of news on vaccines. The latest news today from Pfizer, which is really the first big drug maker that came out with early results suggesting that their vaccine was effective, and we'll talk about why.
Mhm.
Said, listen, we're in the position where we are going to go to the FDA in a matter of days, and we are going to ask for emergency use authorization because we're that confident with the results that this can be given to
Mhm.
people. Now, this is Pfizer, and there's a drug maker, Moderna. They're using a
Mhm.
similar vaccine technology that has never been approved, emergency use or otherwise, ever in history. mRNA vaccine is what it's called. I've asked you to explain this to me probably, I don't know, 3 dozen times at this point, because it's really a lot to wrap your head around. I think I've gotten it, but in the most basic language, what makes this technology different?
Yeah. So the mRNA vaccine, the advantages of it is it can be more rapidly made and kind of more cheaply made, which is why potentially why we see two of the leaders being mRNA vaccines. What it does is kind of does the same thing that a virus does in your body. A virus and the mRNA vaccine, what they do is they inject just some mRNA. So everybody remembers what DNA is. So essentially DNA, if DNA is your,
no, we do.
right? some eighth grade biology professor of your teacher of yours, Jenna, may not be so pleased you just said that. So your DNA is like your printer, okay? And then it prints your RNA, and then your mRNA is like the little piece of paper that it prints out, okay, of your instructions of what to do. So this is actually just injecting the mRNA into the cell, and then you use the cell's own ribosomes, your cell's own equipment to manufacture just the spike protein. Now, everybody remember the spike protein on the virus? The outside of the COVID virus has this little spike protein, which is unique to the COVID virus.
And it's why we call it the coronavirus, because corona means crown. And so the little spike is what is notable about this, distinguishing this virus.
Right. It creates this little halo. I think they thought that looks like the corona of the sun is in fact what it came from.
Yikes, different. Kind of a tough association at this point, but yes, go on.
a lot of things there. But so essentially what it does is just creates a spike protein. Now your body is going to go see that spike protein and create antibodies to it, and also T cells, other immune system reactions to just this spike protein. What's kind of an advantage of it is they're not injecting an actual virus into you. So you're just going to, and when your body produces it, it's just producing this little spike protein, which looks like the actual virus, but it's just the part of it. So
is there any danger to that though? Because I mean, that's something that your body wouldn't know how to produce otherwise. And so the fact that we're giving our body a blueprint to produce something we wouldn't normally produce, to identify it so that we can ward against it, seems like a little bit, science fiction movie-ish.
Yes.
Like bells. There's some bells going off, but I don't know why.
Like Twilight music. So yeah, there are risks to any time you use anything with mRNA or any genetics. So yes, there are risks. That's why we've not seen anything come to market in terms of a vaccine using mRNA. That's why we want to be able to watch the longer term safety effects.
The big question is, what are the risks? Like, what are the risks to this particular technology? Is there anything different about it that we should know since it's new?
Yeah, so there's always a risk anytime you're doing something that involves genetics. So, and we've seen this in some when they try to do mRNA with prior SARS, MERS vaccines and try to do it there. You have things like the vaccine-associated disease exacerbation and other things. That the reality is,
can I pause you? That yes. Actually is that if it can actually make the body's reaction worse. Is that what Dr. Fauci had been talking about? That's just always it's always a risk that if there's something that's not I don't want to say not good, but if there's something that's negative about a vaccine, it can actually make your body experience this disease at a heightened level, which is exactly the opposite to what you want.
Yeah, exactly. I think that those are rare and they're largely theoretical. So we don't want those risks to really be concerning people, but that's also why I'm saying we need to be continuing to monitor for safety and long-term effects, which is what Pfizer is doing. They're not, this phase 3 trial they're doing is going to continue for an ongoing 2 years.
Right, but some vaccine development takes a decade, right? Previously, we've seen it take, at least several years. This is a fast timeline, no matter how you cut it, right? No matter how the cookie crumbles, it's fast. So
it is.
Can it be trusted?
It's important to know it's fast because for a couple of reasons. It's fast because this mRNA allows you to be fast. It allows you to find that target very quickly. It's also fast because usually you do phase 1 and then 2 and then 3, and then you find, oh, this works. Now let's figure out how to get it to the public. And instead of that, the companies, either due to funding from the government, which has been helpful, or the company are self-funding themselves because Pfizer's self-funding it, saying, we're going to put that financial money at risk. While we're figuring out what works, let's just put our money down to figure out how to get it to people. So there's things that are happening in parallel that are shortening it. Those things themselves don't compromise safety. They're just going to help speed it up. But yeah, I think we got to watch and monitor the safety effects. And that's why I also think we need to balance this. The vaccine, it should go to first to people who are at highest risk, where the risk of COVID is going to outweigh the risk of some adverse safety effect from the vaccine. So the people I recommend that get this vaccine first are those people who are older, who are chronically ill at any age. So older people who are chronically ill, those who are at most risk of an adverse effect of COVID should be the ones getting this vaccine first.
there's talk that healthcare professionals would be among the first to receive the vaccine. Would you take it if it was offered to you?
So this is a great question. I have talked to a number of physicians that I work with, and it has run the gamut from some who said, many have said, I'm on the trial. I'm on the Moderna or the Pfizer trial. I'm letting them inject it in my arm before it's even approved. So I have these who say, like, I want it and I got it. Some said they signed up for the trial because they were just hoping to get the vaccine early.
Wow.
So there's that. And then I have other friends who say, no, I'm not going to get it. Or really more, which is where I am, which is I just want to see the data. And the data's not out yet, not due to any nefarious practice. It's just we've had press releases and we haven't seen the peer reviewed data. So we want to know. And I have other questions, Jenna. Like I want to know what we've seen from the data is that these vaccines, Pfizer and Moderna's, they reduce symptomatic COVID. What we don't know is, does it reduce actual diagnosis of COVID? Because what they did is they vaccinated people, they gave them their 2 doses, and they just said, we're going to check in with you. Let us know if you're symptomatic. And if you were symptomatic, then we'll get you tested. What I wish they could have done.
Oh, I see. So basically, and this is an important part about vaccine trials I didn't know, that you need a certain level of infection in the community to test them. You want a certain level of transmission, because you're basically injecting people with the vaccine and letting them live their lives and seeing what happens to them then. But they didn't test people. So because there's a high amount, according to what health officials are saying, what they think is a high amount of asymptomatic cases, there's no way of knowing if someone got the vaccine, got COVID, was asymptomatic, could have spread it to 20 people, right?
Yep.
But is looking like they were protected by the vaccine in the trial. Is that correct?
Exactly. Yeah. And so there's 2 separate issues there. But yes, you're exactly right. The only way to know that would be to take all 30,000 or 40,000 for Pfizer, all those people that they vaccinated, and then a week later test them, and maybe a week after that test them, and continually test them. But they didn't do that, probably because of the thousands of people and the logistics. But as a result, we only know that it reduces the symptoms. We also know that it reduces the severity of COVID. But that's why we should aim it at the people who are most likely to get severely ill. So that means it'll reduce hospitalizations, it will reduce deaths. Those are all really great things. But unless we know if it actually reduces COVID diagnoses, that we won't know if it actually reduces transmission.
And so that's interesting, just because of past studies with this mRNA vaccine technology, there's been questions about, again, durability, the endurance of the sort of immunity that you would get. That would be really interesting to find out, because we do know it's 2 doses, and in many of these cases, 2 doses. That 2 doses every year, every 2 years, 3 years. Is it 2 doses every 6 months? This is interesting. So this is from the press release. The first primary objective analysis is based on 170 cases of COVID-19. 162 cases of COVID-19 were observed in the placebo group, so they didn't get the vaccine, versus 8 cases in the other group that got it, which is interesting because, and they went on to say the observed efficacy in adults over 65 was 94%. So they're saying specifically for this higher risk category. But what I think is interesting about this is that it's a realization that some got the vaccine and some still got COVID. That vaccination is not 100%, that it's not suddenly this blanket cure. But I think sometimes we're talking about it that way.
Well, it's a key tool. And a 94% effective vaccine, I mean, that's great. I mean, let's remember, like, the flu vaccine is 40 to 60% effective, and it's still a really important tool, because
I know, because I get it, and then I'm the person that gets the flu and gets the flu vaccine. That's just who I am.
You just get unlucky.
That's how we became friends. I was like calling you nonstop while pregnant.
But like, just think about it. You wear your seatbelt. Your seatbelt reduces your risk of dying in a car accident by about half. So a risk reduction of half, I'll take it. So a risk reduction of 94% is very good. So let's be happy with that. And especially in the older population, that's very encouraging.
Okay, so then that leads to kind of a final question here, is that what is a reasonable expectation? What is a reasonable expectation for all that we're seeing? We're seeing higher cases, we're seeing higher hospitalizations, we're seeing higher deaths. At the same time, we just got news this week about an at-home COVID-19 test that will be available in the spring, more widely available in the spring, which would allow us all, if we would like to test ourselves, that could be an interesting tool. Then we have these vaccines. We also have these therapeutics coming out. So what does the solution look like? What is reasonable for where we're at right now in this pandemic? I know that's a big question, but how do you kind of ballpark that?
Well, I think it's really going to be a multi-layered solution. We are not going to see one thing that says because of this one thing we did or this therapeutic, poof, COVID magically went away. It's going to be a multi-layer. Again, to use the car analogy, you get in your car, you put on your seatbelt, you have airbags, you also follow the speed limit, you don't like drive while intoxicated. You do a number of different things, and all of those things together mean they significantly increase our rate of safety in the car. So it's going to be, and I think what's going to happen is I think everybody, there's a light at the end of the tunnel. I think it's going to be frustrating for a couple more months, especially as we go through the cold season and as we're still ramping things up. But in the next couple of months, we're going to have more therapeutics. We're seeing that from the convalescent plasma, the monoclonal antibodies, the Eli Lilly product coming out, some other immunologic therapies that are really important. We're going to have vaccines at some point available at a minimum for the people who are critically ill. And we do that plus the safety protocols. All of those things together are how we're going to kind of get back to normal.
What do you think the timeline is on that, though? Like no children have been tested with these vaccine trials under the age of 12. So
Right.
we know that this is not available. And there's some groups that are really advocating for that because they're saying, hey, there's 1 million cases of COVID-19 in kids right now in America. So we should expand the trials. But obviously, that's a really big deal for someone to enroll
Yeah.
their child in a vaccine trial. I don't think I'd be comfortable with it.
Yeah.
But
And I don't think we necessarily have to, Jenna. I mean, I think there are those children who are at very high risk of COVID, and maybe you start to study in that subsector. But I think we're learning, and we're still learning. We're seeing from schools and things.
no,
What?
and that's the reason is that because of schools, because looking into the future, there's a question, well, how, getting back to normal, if this vaccine doesn't really affect the wide swath of the population within the next year, we could be in exactly the situation. We could be better off, but still in this situation next Thanksgiving, where we're getting
So,
recommendations not to travel and our kids may be in and out of school, and that we're
yeah.
really still, kind of in these rolling alerts. And what changes that? What is the key to changing that?
Right. So again, if you can get somewhere between 60 to 80% of the population vaccinated, that's going to be a big deal. So that is how we can get herd immunity from this. So that does not include necessarily having to do younger kids. Another thing is if we don't show that if we show that all this vaccine does is decrease severity, but doesn't decrease actual diagnosis, then there's no point in giving it to otherwise healthy younger kids because they're the ones who are primarily asymptomatic. They're not getting severely ill. And thirdly, like if we can get this widespread to the chronically ill, to the general population, we're going to be able to tamp down on it without necessarily having to do widespread vaccination for kids. So again, for all those
Interesting.
parents who are like, wait, there's no vaccine trials in kids, I don't think that's a bad thing. I think we can get back to normal without having to do widespread vaccines in kids.
I think there's both. There's the parents that are like, why are we not testing in kids? And other parents that are worried that somehow their child is going to be required to get this vaccine at some point over the next several years, and not feeling comfortable with that. And we've seen, this kind of a new movement towards mandatory flu vaccines, for example. And so there's different, it's changing every day. There's a lot of reasons to worry. This is why it's great to kind of go through these conversations, because it's nice to just have a little time to hear from someone who treats this illness. What is this really like? And also because you're a mom. Okay, final question. What are you doing for Thanksgiving? I mean, how are you? What are we doing? Are we doing a Zoom? What are we doing? What are we doing?
I hope it gives your viewers some encouragement to know that I am going through the exact same angst that every single one of them is going through. So just lay that out there. Like hello boat, we're in the same one. As an ER doctor, like we triage. Like that's one of the key things is like which of these 40 patients who just rolled in, which one is most in danger that I have to take care of first. And that's where I think Thanksgiving is coming from, because I think the CDC is saying, listen, here are the most important things, and here's what I think. Maybe I'm putting this on them, but the most important things. We want to keep our schools open. We want to keep our hospitals from being overflowed. We want to keep our economy as much as possible running, even if that's 60 or 70%, maybe up to 80%. We want to keep those things. So this is what's most important. Where are some other things? Where is going to a concert? Okay, that's down here. Sorry, Bruce Springsteen, but that's down here. Where is going to a restaurant or Thanksgiving? That's down here. So again, the Thanksgiving and saying don't go to Thanksgiving isn't because we are running around like Chicken Little saying the sky is falling. We're just saying that in the big scheme of things, Thanksgiving and being able to celebrate this year with your family, the normal turkey day, is lower in priority. And that's where I think they're coming from. At least that's why I'm advocating for a safer Thanksgiving.
Well, I think your gut instinct on that, as we were listening to the call, I don't think it's too far to go off, and it's sharing a little bit of editorial. I've been on a lot of these CDC calls. Um, you know, I think if they felt this way, they would have done this call. I think they would have done this call a week ago. I think there was some urgency here about the numbers that they saw, and that it changed pretty rapidly. I know they're in the know of all the numbers, but I just got that sense, because why wouldn't they want to give everybody more of a heads up? But if they did give everyone a heads up and the cases weren't on the rise, then they could also look alarmist and be completely ignored. So it's a very tough public messaging job that they have to do. So, but are you staying home? What are you doing?
Yeah. So we are probably staying home. I have just some immediate family. If we did anything, it would just be with my parents who are healthy and my two brothers. So it'd be just those four people if we do something. I've given them some rules. I've said we are only getting together if for the week to 2 weeks prior to Thanksgiving, you are able to follow these things. You are only going to work. You are wearing a mask fully at work. You are distancing. You are not doing other social things. If you're able to do that and get tested once, maybe twice using PCR, then we will be able to get together. We might just be driving up there. It's an hour away. So not a far drive, driving up for dinner and not staying there in the same house.
And outside, being outside for dinner?
Yep. Yeah. And but that's what's challenging is I love to have my Thanksgiving plans planned out. And I think you and I are talking about this. We can't. So I have a plan A, and if that falls through, a plan B. And I think that's how we should all handle it with our families. If there's somebody who's feeling difficult, if there's somebody who is feeling offended, then just say, here's the objective things that have to happen. And if they can't make that happen, if they're not willing, then that's okay. It's because of those objective things. It's not because of the family member. It's not because you love them any less. It's just that we have some criteria we have to meet this year.
Are you the most popular person in your family?
I'm the COVID police. I am the COVID police.
Just wondering, I know it's not a popularity contest, but I know. Listen, this is very hard because it is. People take it really personally. And I know I take it personally sometimes. And, it's like, this is the moment for grace. We're all just doing the best that we can with the information as it becomes available. And today is a perfect example, like new information becomes available and you have to switch gears. It's not an easy place to be. It's not, but
it's hard for everybody.
We're actually doing something on Smarter News. I'm just marking it's the anniversary of the Gettysburg Address. And I was going over it with Trace, my 6-year-old, and there's some pretty amazing photos to the Library of Congress of the Battle of Gettysburg. And, it gave me some perspective. I mean, that's a really poignant event. Obviously, the Gettysburg Address is so powerful still. If you read it, I almost was getting teared up reading it to him. We have to keep our challenges in the right context. And I'm not trying to suggest that what we're going through is not like no big deal. That's frivolous. No, we're real concerns on all levels for our personal safety, for our health, for the health of our businesses, our families. This is real. A little perspective's not bad too. So we still have a lot to be grateful for. That's, I guess.
I love that. I think of that every time after I leave an ER shift we may not be able to do Thanksgiving the way we like to right now, but my kids are healthy. My family's healthy. And we have to be grateful for those things. I guess that's what Thanksgiving is about, is that refocusing.
We're grateful for you. Thank you, Dr. Darria.
I'm grateful for Smarter News.
Thank you so much to Dr. Darria for that great insight on these topics that are so impacting all of our lives right now. We really appreciate it. Questions and comments, please let us know. And as always, more on smarternews.com.